All right, so welcome back to day 2 of the 2020 Saskatchewan Health Research Showcase. If yesterday's anything to go by, I think we have another amazing day of presentations lined up for everyone. My name is Chris Plishka. I'm the Methods Platform Lead at the Saskatchewan Centre for Patient-Oriented Research, or SCPOR. SCPOR is excited to be co-hosting the event today with the Saskatchewan Health Authority. To start off with, I'd like to take this opportunity to acknowledge that the event today is being hosted from Saskatoon, Saskatchewan, which is located on Treaty 6 territory. Treaty 6 territory is the traditional territory of numerous First Nations, including the Cree, Anishinaabe, Nakota, Lakota, and Dakota peoples. Treaty 6 territory is also the homeland of the Métis people. Many of the members of the planning committee and presenters for this event are also located in Regina, Saskatchewan, which is located on Treaty 4 territory. I recognize and understand that the relationship between SCPOR and the Indigenous peoples of this land is guided by the treaty relationships. Personally, my ancestors came to this area from Ukraine around 120 years ago, and this may not have been possible if the treaties had not been signed. In addition, I currently live and work in Treaty 6 territory, so I acknowledge that my day-to-day activities are influenced by the treaties that have been signed. Before we jump into the session, I have a few quick reminders for you. The chat box is being monitored by an IT specialist, or chat box is being monitored and an IT specialist is also in attendance. The sessions this morning will be recorded. If you're having any problems connecting to Zoom, then you can call 306-766-5140. The presenter will be spotlighted during the presentation. Attendee mics will be off during the presentation, although attendees are encouraged to keep their cameras on. Questions can be written in the chat box, and then they'll be addressed at the end of the presentation. You can also use the raise hand function to ask questions in Zoom. If you do this, then we'll come and unmute you. When you are asking a question, please introduce yourself and where you're from. Speak loudly and clearly. Try to limit yourself to one question and ensure that the question is related to the presentations. Also encouraging everyone to visit the SK Research Showcase website and check out the posters that are available there. There were a lot of great submissions. Sadly, we couldn't give everyone a chance to do an oral presentation. And if you like one of the posters, make a comment or reach out to the presenters. Researchers put a lot of time into their projects. It's always great to hear or when someone lets them know that their work's being appreciated. Also, following the end of this showcase, all attendees will receive a survey. We ask everyone to please take a few minutes to complete it. So today's session will focus on community research. Presenters will either focus on community-based research or research priorities which are informed by community-based organizations. We'll have 4 presenters. Each team will present for about 8 minutes. Each team will have about 8 minutes to present, and then we'll leave 2 minutes for questions. Based on what I know about today's presenters, I'm confident we're going to have 4 amazing presentations. So first, our first presenter is Dr. Shella Hirani, who is an associate professor at the University of Regina. Her presentation is titled Knowledge Mobilization Tool to Promote, Protect, and Support Breastfeeding During COVID-19. I'll turn it over to Shella.
Hello, everyone. The topic of my today's presentation is Knowledge Mobilization Tool to Promote, Protect, and Support Breastfeeding during COVID-19. Can I have the permission to please share my screen? So can I share my presentations with the audience?
Do you want to try that now, Shella? If not, then we will tweak
just
things to make sure you can.
Presentations in here. Just a second. I'm just trying to upload, but I'm unable to just see the screen where my presentation is located.
No worries. We started it a little ahead of time, so we'll make sure you get your full time to present anyways.
Yeah. I'm just trying to hit the share button, but it's not going through. Can you please help me out in that regard? Yeah, it's here. Thank you. So good morning, everybody. I'm Dr. Shella Hirani, Associate Professor at the University of Regina, Faculty of Nursing. The topic of my today's presentation is Knowledge Mobilization Tool to promote, protect, and support breastfeeding during COVID-19. I would like to acknowledge my team members, Amanda Lenovi, who is from United Way Regina, and Megan Pierce, who is the research assistant on this project, also the skipper trainee from UOFAR. COVID-19 pandemic and breastfeeding, just to let you know some background about it, that how we just thought of starting with this important project. So we all know that COVID-19 pandemic has really put a tremendous effect on the lives of every individual, but unfortunately, the mothers and the young children are the most vulnerable group. And why they are so? Because there are lack of opportunities to have the regular contact with the healthcare professionals. Especially there were previously the well baby clinics that were no more in effect during the time of the COVID-19. Also, mothers were facing the issues including the inaccessibility to the breastfeeding counseling facilities during this pandemic. Also, there has been lots of discrepancies in the initially available literature about the recommendations whether the mother should breastfeed, should remain separated from their children soon after the childbirth, or is direct breastfeeding recommended or not, how safe it is to have the express breast milk provided to the young child. And these were few of the initial questions that initial literature talked about. But also in April, when WHO recommended that breastfeeding mothers should continue with the breastfeeding even during this pandemic because the benefits actually overweighed the risk, this was a time when we as a team realized that we do not really have easy to understand, evidence-based and accessible resources for the breastfeeding mothers. And that really required the crucial need to promote, protect, and support the breastfeeding practices during COVID-19 pandemic by designing a knowledge dissemination tool. Therefore, the goal of our knowledge mobilization project was basically to develop and disseminate the e-resources to the breastfeeding mothers who may not have the access to the breastfeeding services during COVID-19 pandemic. We also wanted to clarify various myths and misconceptions surrounding breastfeeding during the time of pandemic. And we also wanted to raise the public awareness on the safe infant practices during pandemic. So we actually undertook this particular project into the various phases. During the phase 1, we basically undertook the need assessment of the breastfeeding mothers during this pandemic. In this regard, we had the discussion with the breastfeeding mothers who were actually the end user of our project. We also collaborated with the healthcare professionals and community patient-based partners and organizations who were actually providing the direct services to the breastfeeding mothers. And that's how we reached to the decision of developing an e-resources on the breastfeeding during COVID-19 so that we can really provide the need-based guidance to the mothers who were really requiring the lactation support at that point in time. During phase 2, we reviewed the evidence-based literature and reviewed the recommendations for the breastfeeding mothers during COVID-19, to what extent they should wear the mask, whether it is safe to provide the breast milk or not, and how exactly mothers should take care of herself and the child during this difficult time. And we basically reviewed the recommendations from 23 organizations, and we analyzed what are the differences and what are the discrepancies. And based on that, we really reached to that center point that everybody is recommending the breastfeeding during COVID-19 with some extra added measures. During phase 3, we actually developed the e-resource. And one of the e-resource we had was the animated video on the breastfeeding during COVID-19 as an information guide. And we used the evidence-based resources to develop this particular video. This was a 5-minute animated video that was conceptualized, developed, and posted publicly on YouTube. And that's how it was made accessible to everybody. The video covered the number of subtopics. One of those were benefits of breast milk. We started with how breast milk can actually benefit mothers during this difficult time. And again, what are the true advantage of providing the breast milk rather than any other kind of milk during this point in time. The video also covers the ways that breastfeeding mothers can protect themselves and young children from COVID-19. And we clearly indicated that what mothers should do exactly if she's having the symptoms. There is a need to wear the mask. And also if there is some healthy caregiver can actually look after the child's need during other time when child is not being breastfed. That was something we emphasized in this video. We also talked about the alternate feeding option if breastfeeding is not possible for a shorter time period. So we can just promote the health of the young children during this pandemic as much as possible. We also talked about in this video the precautions during COVID-19 that mothers should take. And we also had the demonstration on the 20-second hand washing steps, and we provided the short clip on how to prepare the home-based disposable mask for the mothers who have to breastfeed with some symptoms during that difficult time. The video also highlighted some of the important aspects for mothers, including their personal self-care, which is equally important during this time so that mothers can have a very good mental health and can provide the best possible care to the child during pandemic. During phase 3, we actually launched the Facebook page where we also uploaded the video. Also, timely basis, we assured that we upload some of the evidence-based posters from WHO, UNICEF, and other authentic organizations as far as they have any precautions in place for the mothers. And the good part was that the Facebook really work very well. Many mothers actually access it, and we have number of followers right now on this page. The fourth phase was the dissemination of the e-resources. So one e-resource that we had was the animated video, and other was the Facebook page through which we were regularly communicating with the mothers and also disseminating the number of evidence-based posters and animated videos to the mothers and different agencies. So video altogether was distributed to 113 agencies and stakeholders locally in Saskatchewan. And we did it with the help of our partner, community-based partner, United Way. The video has number of views. Until October, it was 1,250 plus views. Most of our viewers and end users were females, and most of the target population, initially we were targeting it to Saskatchewan, but it was good to know that it was having the audience from all over in Canada as well as the United States and other countries. We also launched the Facebook page, as I mentioned, and it has many followers, and many times it had many public engagement, and people were asking questions, accessing those posters and evidence-based literature and the animated video, and were really benefiting from it. Some of the feedback that we received from the end user that they found the e-resources very informative, user-friendly, and useful. They also commented that it was the easily accessible for the breastfeeding mothers and breastfeeding supporter, and such a resources should be there online during the time of pandemic. They also admired the visual representations, and they found it quite engaging because we used the animated video and not the real person in that one. And then we also received the recommendation for having more future e-resources that are short, easy to understand, and also available in the different languages. So just to discuss the main point that from this project, we came to know that how important are the e-resources and how effective they are as an avenue to promote, protect, and support the breastfeeding during COVID-19. So literature also support the similar finding that the access to the online resources are quite helpful for the breastfeeding mothers, especially during the time when face-to-face interactions are not possible. Literature also highlighted that mothers prefer the accessing the information about breastfeeding through technological mediums such as smartphone applications, and pregnancy and parenting websites and internet and the online videos. So with that, the final few recommendations that we came out from this project is that healthcare professionals and service providers must and should recommend and use the evidence-based resources to promote and protect the breastfeeding practices. And these resources should be knowledge-based, easily accessible to the public, must be using the simple language, and must be available in the different languages. So everybody from different cultural group can also benefit from that. Few other recommendations from this project was that the creation of the e-resources on the breastfeeding actually benefits the breastfeeding mothers, but for development of these resources, we really need the evidence-based literature. And with that, the patient engagement and collaboration with the patient partner is very, very important so that we can benefit the community at large. And we are also knowing what are the real needs of the community. Also, utilization of the social media platforms, we found it quite useful, and we also recommended very highly to use the social media platforms to promote the breastfeeding practices during the COVID-19 and the pandemic like those, where the face-to-face interactions are not much possible. Here are the references that I use in this presentation. I would like to acknowledge the breastfeeding mothers who are the patient partners. I would like to acknowledge Saskatchewan Health Research Fund, SCHRF and SCPOR for the funding on this project. We also would like to acknowledge University of Regina Faculty of Nursing, who was the funding partner, and also United Way Regina that really helped and supported this project by disseminating the resources to the end users and to the variety of stakeholders. Here are my contact details. If anybody has a question on this presentation on project, they are most welcome to write to me at this email. I also have a link in here on the YouTube video, the animated video that we created out of this project. Thank you so much. And now the floor is open for the questions.
Thanks, Sheila. Great presentation and really exciting work there. We're running a little bit late, so might have to just have questions in the chat and let everybody else or have some discussions there. I'm wondering if you want to share the links to your YouTube page and the Facebook site in the chat, just so that everyone has access to them. I know it's kind of hard to copy and paste out of presentations for other people sometime. But yeah, I've pretty strict orders to keep us on schedule. So I'm going to turn it over to Michelle and Justine next. So the second presentation will come from Michelle Pavlov, who's a researcher with Sask Polytechnic, and Justine Lustig, who's a patient family partner with the team. Their presentation is titled Saskatchewan Farmer and Rancher Mental Health Initiative. So we'll make sure that they have access to share their screen and turn it over to them.
Thank you, Chris. I am going to hope and pray that my farm internet gets me through this. And if it doesn't, I'll log back in on my phone, but I'm going to go ahead and share my screen.
Looks like it's working well,
Perfect.
Michelle, so take it away.
Thank you. Oh, hi, Justine. I see you got on okay. Good to see you. Good morning. Thanks, everyone, for coming to our presentation today. So this is about our initiative. We went with the name initiative instead of project, and we're exploring farmer and rancher mental health in Saskatchewan. So I'm going to start the presentation, and Justine, our very important patient family partner, is going to co-host with me today, and she's a rancher in Saskatchewan. So we have a few co-authors on the presentation today that I would like to acknowledge. And we will go ahead with our outline here. So we'll talk a little bit about our project, our team, which is very large. I'm very grateful and humbled to be on this team. We're just working with brilliant people. We're going to talk about why this project is important to Saskatchewan agricultural producers and their families. Then we'll chat a little bit about why this project is important for healthcare providers. And then Justine's going to talk to us a little bit about farm culture. So our project is truly patient-oriented. When I had thought about doing this project a few years ago, I didn't have a budget and I thought, oh, I'm going to do a provincial survey. It's economical, it's easy, we'll get it out there. My first meeting with my patient family partners, they respectfully said that is a terrible idea. Farmers hate surveys, they're going to throw them in the garbage. We need to go ride around in the banker seat and collect this data ourselves. So I had to find out that the banker seat meant that they were going to ride around in the tractor or the combine and collect this data from the farmers and ranchers. And so it was a very unique start to the project, and I love that they just turned it on its head and we're doing something completely different, and it's way better than anything I imagined. So I'm grateful for their insight and their ideas. We did apply for and were successful getting a Sprout grant, so that has really carried us through so far, and we're very grateful for that. Also want to acknowledge funding from Saskatchewan Polytechnic, SCPOR, SHERF, and Syngenta has also given us some funds for this project. So our research question, and we went back and forth a lot on this, but our patient family partners came to this conclusion. So what can be done to build trust for agricultural producers and their families to access mental health services that are farm culture friendly? So the purpose of our study is to assess barriers that farmers and ranchers and their families encounter when they're trying to access mental health services. We want to explore how trust can be built for farmers and ranchers and their families to access those services, and determine which services would be most useful for agricultural producers, and what kind of service delivery would best fit farm culture and their needs, and then describe agricultural and producers and their families' view of what farm culture is. So this is a mixed methods design in 2 phases. Phase 1 is going to be semi-structured interviews with farmers and ranchers on their farms when it's COVID safe to do so. So our patient family partners were very keen on being part of the data collection, and it was very important to them that they built those relationships with the participants. So whether that was going to help them fix fence or fix a swather, whatever that looked like, going to visit during calving, they wanted to collect data on the farm with the farmers and ranchers. So when we're able to go out and do that after COVID, we're going to actually go out to the farms and do that. Our patient family partners have been educated to conduct semi-structured interviews, and we'll bring a researcher along for that data collection. And then phase 2 is actually going to be an intervention program or resource based on our findings from phase 1. So we'll pilot that and see what would be most effective for the people in this province. Our integrated knowledge mobilization is a little bit different than our typical academic conferences and publications. We are going to go to our agricultural trade shows once COVID's over. So we'd like to get to the Farm Progress Show and Agribition. And the patient family partners have said, hey, let's build like a truck bed and have popcorn and balloons for people and make it a welcoming place for people to come and have like a tailgate party. And so the way that we're going to get the word out about our study and our findings is going to be a little bit different than what we would traditionally do. So I'm really enjoying that part of the project. It's been very fun. So on our team, we have 4 patient family partners who are farmers or ranchers in Saskatchewan. Academic researchers, Dr. Kevin Wasco is on our team. We have a social worker, a rural suicide interventionist. Dr. Michael Saffron, our public health biostatistician, is going to help us with phase 2. We have RNs, NPs, an online therapy business owner, a psychotherapist. We have a massage therapist and acupuncturist who works in a rural area. And then we have a team of undergraduate student research assistants and a research facilitator. So Justine, I'm going to pass this over to you to do the next slide.
This project's very important for farmers like me in Saskatchewan because farmers and ranchers very rarely access mental health services, and we are seeing some very concerning statistics. The stress, anxiety, and depression scores are 6 to 8% higher than overall population, but more concerning is that burnout among farmers is characterized as being ineffective overextended, and disengaged, and up to 44% of farmers are feeling burnt out. This is very concerning for us as a population, but also for the overall Canadian agriculture sector because of lowered productivity. If we're burnt out, we can't do our best work. And in Canada, statistics are not taken sector by sector, so we don't know particularly what farmers are doing for the suicide rates. But one study from the University of Regina has found that suicide rates among farmers and ranchers is 30% higher than other occupations. And in the USA, they take suicide rates by sector. And for farmers and ranchers, it's 5 times higher than other occupations. So we can extrapolate that a little bit for Canada and recognize that this is a big problem.
Thanks, Justine. Oh, I'm trying to go to my next slide. And it's not going. Well, for time's sake, I'm just going to, I'm going to keep talking here and I'll keep trying to go to my next slide. So why is this project important for healthcare providers? So as healthcare providers, we're always trying to provide culturally appropriate care. And so what does that look like for farm culture? So if we have a farmer or a rancher that comes in and they're very proud and very stoic and they come in and they're asking for help, what are we doing to show them that we really understand their culture and that we really understand where they're coming from? So, you know, the services that we deliver to farmers and ranchers, if we don't let them know that we understand where they're coming from, we're going to shut the door right away. So if we have conversations like, you know, you really should take some time off, or maybe you should think about another profession, we've lost them. They're gone. They don't want to talk to us because they don't get that feeling like we understand where they're coming from. So that is very key.
And I'll speak a little bit about farm culture, continuing from what Michelle has said. They can't stop working, especially at some key times during the year, like calving and harvest, seeding. A lot of the work that they do is very time sensitive. And since the whole family is involved in the work on the farm, we're also expected to leave a legacy and have a successful farm for generations. And this can result in shame if we can't cope with the pressure. And the age demographic of many farmers means that they're not talking or even thinking about their feelings. So we need to normalize farmers and ranchers getting mental health support. Another barrier is that self-employed individuals do not have access to healthcare benefits. And so farmers do not have access to pay for therapy or even things like massage and chiropractor out of pocket. So if they are going to access mental health support, it's going to be through the health region. And in a small town, that often means they know personally the person who is providing this, and it can feel awkward to confide in someone like that. So we are going to further explore what farm culture means to farmers and ranchers as we do this project and collect the data. And then the intervention that we create will be based off of how we can most help people being farm culture sensitive.
Okay, so I see that we're almost at the 10-minute mark. So we could, I don't know, Chris, if you want to leave maybe a minute for questions, or if people just want to put it up in the chat box to stay on schedule today.
Yeah, I think we have opportunity for probably one question, and then having it in the chat box has worked really good so far, it looks like. So if we have anyone who, looks like we have M. King snuck in the first question. So I'm not sure if that's Maggie, but we will turn it over to them to unmute themselves and ask a question.
Good morning. Yes, it's Maggie King. I was wanting to know if in your discussions with the farmers, if their stress is related to the nature of their farming practices and the economy, and whether there is a discussion on any kind of alternate methods of farming that may be contributing to carbon sequestering practices in farming. I'm just wondering if any of that discussion took place. I think it's important that farmers be able to look to alternatives if the current farming practices are not working.
I can speak to that. Since we haven't done any of the data collection yet because of COVID, that discussion hasn't been had with the farmers, but we did have that discussion within our research group. And I personally, we are regenerative farmers, and but we don't want to push any beliefs on anyone as we're interviewing them. We just want to take data collection of where they're at with their mental health. And a big part of that is the economy and how things are handled. And so we want to make sure that we are inclusive in any kind of farming that we are discussing with our patients, and definitely giving the option to learn about these other types of farm practices might be helpful, but mostly we're focusing on the healthcare aspect.
Thank you.
Thanks for asking.
I'm glad it's being thought of. Thanks.
Yes.
So it looks like there's a few more questions in the chat, so I'll encourage you guys to go check that out. Lots of compliments there. And then we'll turn it over to our next team. So our third team of presenters is Nilu Sachdev, Kirandeep Bular, and Pat Falconbridge. Their presentation is titled Working Together to Achieve Better Care, Better Health for Newcomers to Regina, Saskatchewan. So we'll turn it over to them for their presentation.
Good morning. My name is Nilu Sachdev, and we're just getting our slides put up right now. Regina Immigrant Women's Center is a community-based organization in Regina working with newcomers. And as has been said, our presentation is entitled Working Together to Achieve Better Care and Better Health for Newcomers to Regina. I am the executive director at Regina Immigrant Women's Center and the principal investigator. My team are my colleagues, Dr. Rajni Suther, Karen Puller, Jan Pyle, and Denise Babcock. And we're going to be taking turns doing some of the slides and giving you a glimpse of our presentation. Karen, would you like to take on?
So believe it was Rajni, but I can start off with this. So our mission is that we provide opportunities, programs, and services for immigrant and refugee women and their families to facilitate and support their smooth integration into local communities. We have two locations presently. Our RIWC main office is on 1801 Toronto Street, and then we also have an English Learning Center at Broadway United Church. Some of you might have come across us at some point, and then our new location is coming up in December of 2020, which will be in the Golden Mile location. So going over the programs, just to give you a scope of the work we do, so we do offer language training programs, and these language training programs for newcomers, they are both federally and provincially funded. They include LINK, which is language instruction for newcomers to Canada, and also STAGES. And the programs, they deliver English as a second language training to newcomer adults, whether they are permanent residents, citizens, work permit holders, all the way from CLB levels 1 through 7. On-site childminding is also available for kids aged 6 months to 6 years. We also have family support and case management program, which provides confidential and culturally affirming counseling, gender-based violence, safety and risk assessments, trauma and violence-informed short-term counseling. And then we also do have employment-focused training programs for newcomers, both youth and adults, One of them being the Youth Employment and Skills Strategies program, which is a 22 weeks upskilling and placement program for newcomer youth between the ages of 15 to 30 years. And then we also have another work readiness program for newcomer adults so that they are trained in the workplace and then they get the exposure to the labor market. We also provide community connections programs, including New Stars, which is a program specially designed for newcomer seniors, HIPPY, which is home instruction for parents of preschool youngsters, which is designed for isolated newcomer mothers of children aged 3 to 4 years. We provide, in partnership with Mackenzie Art Gallery, a program which focuses on art activities for mothers and their children. Another initiative is a wellness initiative for supporting healthy engagement in the settlement of newcomers, which looks at cooking, nutrition, and healthy lifestyle classes for newcomers of different ages. And then we do have a volunteer match program, which provides targeted matching of newcomers with experienced volunteers. We also do have support services. So we do take volunteers in our programs. And this could be, we could engage them with a drop-in conversation class, or it could be one-on-one volunteer matching. It could be the sewing program. So we do have volunteer opportunities. And if you know people who want to volunteer in the community, please let them know about us. We go through the application, the screening process, and an orientation before we put volunteers to work in our programs. We also do get interpreters, and we have trained and screened interpreters in over 30 languages. So just to give you a scope of our program, wanted to share these slides with you. So now we would have, I don't know if she's able to come on. Jan, are you there?
Yeah, I'm here. Can you hear me?
Yes.
Okay, thank you. So some of the challenges our clients and our students face is lack of knowledge, what healthcare services are available and how do people access them. For instance, they may not know what their healthcare covers. They have dental coverage, they have mental health coverage. They don't have knowledge of this necessarily. Also, there's language barriers when they access the website. Language often contains a lot of big words and maybe a lot of links that they may not have the ability to understand. Sometimes they don't know how to access services. For instance, a few weeks ago, I had an early morning email from one of my students who was emailing to tell me he couldn't come to class. The other thing, he said he couldn't come to class because his daughter that he cares for had a really bad stomach ache and it was throwing up, and it was 7 o'clock in the morning and he didn't know what to do. And so there's that kind of information that often is not available to them. Language barriers, they don't understand the English instructions that might be complicated and contain a lot of words. Can we move the slide?
Yeah, I did. Can you see the next slide, Jen?
Thank you. Okay, so current and updated information is not always available on the website. We've had clients complain that the section where there are physicians that are taking new patients, and then when they phone the offices on the website, they find that these physicians are in fact no longer taking new patients. So out-of-date information on the website is a problem. Also, the need for trained language interpreters who can assist with translation. You can't just bring the friend from down the street who speaks a little better English than they do, because there's no saying that that person can actually translate and interpret medical information. And also a need for culturally responsive services. For instance, maybe from some cultures, a female cannot see a male doctor, so there's that to take into consideration as well. So they need to know that, what documentation is needed, that health card is needed. What does the health card cover? What health card services have to be paid out of pocket? And who will cover healthcare expenses for those who are waiting to receive their health card? I had a client who he and his wife came to Canada, and they applied for their health cards on November 4th. She was having a baby in April, and April 1st came, and they still did not have their health cards. And my client was getting pretty anxious. He was given incorrect information by a medical officer that said, oh, if he just went to SHA, they would give him both letters and everything would be fine. When he got to SHA, he found that was not the case. He was being really worried that he was going to have to pay the expenses for their baby's birth upfront, out of pocket, and that he did not have that kind of money. Now, I got to say, Saskatchewan Health came through, provided his wife with a letter, and they didn't have to pay for the birth, so it ended happily. But it caused a lot of stress in that family in the meantime. So, Denise, are you there?
I am, yes. So very nice to be able to share our perspective and the type of work that we do and the type of challenges that our clients have. So I'm teaching levels 1 to 4 in English. So they are just beginning to be successful with that. Some of the challenges that I have run across, and therefore that would also apply in greater force to my students, is as a person who grew up in this province and who also grew up on a farm. So what you were saying about farm supports being needed also rings true for me. I called 811 before I was leaving the country to travel a few months ago, and it was going to be a 2 to 3 hour wait to get to speak to someone. Thankfully, I've heard that has changed, but the complications of the language are very difficult for people to understand. We have seen some depictions in poster form that are very simple to understand, and perhaps communication of that sort would be helpful in areas such as the 811. As Jan mentioned, people do not know what coverage they might have. And what shocked me about my steep learning curve in this area is that people come to this country and do not have any guidance to figure out what do they need and how do they get it. There is no organized support of that sort. So that is really, to me, it emphasizes the amazing courage and respect that they deserve for moving to a new country, which most of us have had the experience many generations before. Like you mentioned, Chris, that your family came 120 years ago. But today we're really grateful that technology is available, but some modifications of that would definitely help newcomers. We have talked about workshops being a possibility. I've had many people of different forms of expertise come into my classes, and it's information the students need, but the amount and the complexity of the communication in the presentation is beyond their scope. But it does open the door for questions they might ask and for information I can provide in more detail afterwards. So having people come in from the health system to provide information is an excellent idea, and it creates a sense of safety. One other comment I'll make, because many of our clients would be traveling, when I returned to Canada and was told I needed to self-isolate, which I was aware of in advance, when I made the phone calls to the correct numbers and so on, the information was not clear. And I grew up speaking English, so I can't imagine what it would be like for somebody trying to translate it, because they were saying that the wording that they used was almost threatening. It was, on the one hand, must do this. On another hand, you have an option to do this. And even though I phoned in every day for 2 weeks, I never had clarification. I just thought, I'll do this because I don't know if it's what I'm supposed to do or not. So there needs to be a lot more clarification on things like isolation. So if we have people come out and talk to our classes, and if we can create a collaborative relationship with Sask Health in conveying information and clarifying, we can be people who can then help these our clients find the right direction and know what they need to do next. So I think this one, when the ideas that Jan mentioned a few minutes ago are gone into in more detail here, where when do you go to a walk-in clinic, and when do you what kind of vaccinations did you have from your previous country, and what kind of documentation do you have, and what do you need here? All of those things are major issues for people who have children. I think that covers everything on this slide. And
so Dr. Suthar, if you are there and if you just wanted to wrap up.
Yes, so to conclude, there is a lot of information that's not being presented in a simple form to the newcomers. Secondly, just as we have a handbook for driving, SGI has come up with a driving handbook. In the same way, we need to have the information in the form of a handbook, which can be provided to the newcomers, because we cannot assume the fact that they will be having the same type of healthcare in their home countries. So we need to provide them the basic information, the hierarchy, the places where they can go and access. So what is actually an emergency or not? So these things need to be presented to the newcomers, and this information, there is a gap that we need to fill by means of a handbook or say an updated website. So there is this need to do work in this area for newcomers, especially health and health-related issues and information. So on this note, Ilu, would you like to?
Yes. Thank you, Rajni. Thank you, Dr. Suthar. Thank you very much. And thank you to the whole team for participating as co-investigators and bringing on this presentation from the Regina Immigrant Women's Center. Now we'll be open for questions. And we've got our contact information here, our website, as well as our phone number. Although we are doing a lot more remote work at this time, but our phones are being answered and we are able to connect with the community. Thank you.
Thanks to the whole team. Just keep us on track. We might have to do questions in the chat for this one too, but great to see the whole team presenting there. And apologies for the beginning. It looks like I missed a few people in my speaking notes. So great to see the whole team there. I know everyone's name is up on the website though, if you need to be in contact with them. Our final team of presenters for the day is Tom Martin, who's a quality and strategy specialist in the accountable care units, Paula Kirk, who's a patient and family advisor, and Dawn Anderson, who's also a patient and family advisor. Their presentation is titled, Just Ask One Question, Patient Experience Surveying in Acute Inpatient Care. So I'll turn it over to them for our last presentation of the session.
Great, thanks very much. And thanks for allowing us to present today, giving us the opportunity. My name is Tom Martin. I'm the Quality Improvement Specialist. And today we're going to present to you on a quality improvement project on the accountable care units at the Pasco Hospital called Improving Care at the Bedside. Just to ask one question. I'm very privileged to be able to present to you today with two accountable care unit patient family advisors, Paula Kirk and Dawn Anderson. For those of you who've never heard of an accountable care unit, basically it's a manner in which we reorganize our traditional hospital ward with the traits of an effective clinical microsystem. It's team-based care of the true essence of the word. In what an accountable care unit does, it combines four foundational elements or features, and they've listed them here. Firstly is the combination of the efforts and the leadership of a nurse manager, a physician, and a patient and family advisor. The second aspect is unit-based teams, and this is where we geographically cohort physicians on one unit where we have the smallest number of physicians available to look after a set of patients, and we team them up with unit-based staff, including nursing and allied health. An accountable care unit uses unit-based routines, which is the use of all the best practices through the use of in communication, specifically in the area of using safety quality checklists, using multidisciplinary rounding, using goal setting with patients. And ACUs are particularly effective in utilizing what's called the structured interdisciplinary bedside rounding, which brings together the doctor, the nurse, and what's available in terms of allied health at the time at the patient's bedside to every single day look at and exchange information to ensure the plan of the day is on everybody's understanding. And the last feature is what we use unit-based metrics to help describe the performance of a unit and help evaluate the performance of the unit altogether. What you see here is how we utilize a dashboard to, as I discussed a second ago, how we analyze and look at performance of an accountable care unit in various different measures through process metrics and performance metrics and clinical performance metrics and also patient satisfaction and unit system outcomes metrics as well. Now, this project was largely looking at identifying how we can extract patient experience information from a more of a qualitative aspect, which can fall in our dashboard here. And essentially, that's what we were destined to do with this project, was see how we could qualitatively evaluate patient experience on an accountable care unit and taking it a step further by utilizing our available accountable care unit patient family advisors, whereby they will be designing and collecting and reporting the data that they have collected. We based this information, this study, we based this project on a study that was found in the UK to have effectively extracted patient experience information by utilizing medical students on medical wards at the bedside, asking a simple question such as, how can I improve your stay today? And then they were able to find categorize and find some very relevant information pertaining to how medical students were able to actually attend to very simple tasks. They were able to address basic care needs and then also solicit suggestions by patients requiring more institutional change. And we took this project and our patient family advisors took the lead in adjusting the question slightly to suggest and ask at the bedside, how can we improve your stay today? And this essentially was a catapult to how we can have been using our PFAs as agents for quality improvement. The project itself was over the course of 3 PDSA cycles or Plan, Do, Study, Act cycles. We addressed and looked at various changes amongst those different cycles. And over the course of about 7 months is where we were able to extract an absolute wealth of information from our patients vis-a-vis our patient and family advisors asking that simple question at the bedside. So Paula, if you're there, we'll have you talk about some of the more details of the methods behind the project.
Great, I am here. So we developed a 7-day rotating schedule that started with us, the PFAs, coming to the wards between 3 and 5 every day from Thursday to Sunday. And then we signed up for shifts for those days and communicated with each other about which patients had already been seen and how many were left to be interviewed. And we entered all of the data that we collected over those 4 days in an online data tracking tool. We're very lucky to have Tom on our team. Any concerns or requests that were actionable in real time by ourselves or the bedside nurse were done immediately at the bedside. And then on Monday, the data we collected was analyzed and sorted into easy to use reports that were sent to unit leadership, including the PFAs, by the ACU analyst. Unit leadership, including us, acted on any concerns brought forward by patients if we hadn't already acted on them. And then on Tuesday and Wednesday, the PFAs would come to the wards and co-present the data to the frontline staff. And Dawn.
Good morning. here's a picture of a group of PFAs presenting the data to the frontline staff. The feedback sessions wouldn't be longer than 15 minutes and would cover all concerns brought forward by patients and would also cover all positive comments mentioned by patients. And there were many of them. Frontline clinicians would attend each feedback session.
So you can see here that out of a total of 579 interviews we conducted with patients, the majority were done with patients who had a hospitalist as their attending physician.
And here there are 579 interviews, 242 of which had a request, 192 did not have a request, but had some general comments to share, and 145 didn't have any request at all.
You can see here the distribution of our requests landed in 4 broad categories: communication, access to service, environmental factors, and care delivery. We deliberately sought advice and help from our patient advocate office on deciding what broad categories to use so that we can start to bring some standardization and generalizability to the process of theming and categorizing concerns and requests from our patients on ACUs. You can see here that the majority of requests fell into the categories of care delivery under responsiveness. First of all, the majority of these requests came in the form of a concern expressed regarding the response time of frontline clinicians to answer their call bell. The vast majority of patients expressed this concern empathetically because they recognized how busy staff were on the ward, and it's largely out of their control as to how quickly their bedside nurse responds to their call bell. For example, many times we would hear the patient say, "The care is great, but it would be nice if nurses could respond quicker to my call bell, but I understand they're so busy." We also saw a lot of reports under environmental factors in the area of meals. A majority of patients expressed concern about the quality of their meals, or they had a request for a better meal. Many of these requests were out of our control and they were passed along to the appropriate department head. In some cases where a meal was either forgotten or wasn't the right one, example, if a diabetic meal was required, we called down to the kitchen and requested a proper meal be brought up for the patient. And the other large category was under environmental factors in the category of other. Here, we heard patients requesting services and items that didn't fall specifically into any of the other categories. For example, some patients requested a more comfortable bed, getting tucked in, help with the TV, help passing items to them, the noisiness of the unit at night, etc. And for many of these requests, we were able to either take care of them right away or seek help from the bedside nurse, the nurse manager, or the unit manager.
And what did we find? You can see here that the PFAs were able to take action on 60 requests that patients had. These requests were something that could be done immediately at the bedside. For example, pass items, fill up their water jug, get them coffee, tuck in the patient's feet. Or they were requests that we sought advice or help from the bedside nurse or the charge nurse. You can also see that many requests, 215, we received were more general in that they weren't something we could take action on right away, but something we could share with the unit leadership the first chance we had. Lastly, the majority of patients, 304, were satisfied enough that day or couldn't think of anything specifically and therefore didn't have any request at all. However, many of these patients still had a general comment about the care they were receiving, and the PFAs captured as much as they could. We also noticed that for the vast majority of our interviews, even if the patient didn't have a specific concern, request, or comment, we quickly built a positive relationship with them. so much so that many of them felt comfortable enough to share personal stories, concerns, and requests that they wouldn't feel comfortable sharing with their bedside nurse or other members of their care team. We felt this to be a very rewarding part of the project and very useful in soliciting real feedback that perhaps wasn't as biased or meaningful to help us understand where and how we can improve the patient care and experience.
Many patients we interviewed had positive things to share with us while we were interviewing them. Many of them also serendipitously had a comment about the ACU related care that they were receiving. The positive comments were leveraged by unit leadership to provide positive reinforcement and a moment of celebration by the unit. Examples of positive comments were 110% pleased with care. The nurses are good, they treat me well. Outside of the food, this patient spoke very highly of the doctor and nurses. Receiving good care, staff are cheerful, prompt, and run off their feet. They are running. Everyone has been super great to me. And some of the ACU related comments, Don?
The patient was very happy with cyber and couldn't say enough good about the whole ACU process. Her son did say his mother was previously at the general and he and his sister were very upset with their mother's care. I like the new system that they have, better on this unit than others. She likes it here, much better than the general, which is chaotic. I'm getting excellent care and I should know because I've been in 3 hospitals. This is the best unit so far.
So a couple of practicalities and opportunity for improvement in regards to this project. Hopefully you've been able to glean already. The patient and family engagement was an absolute tremendous success. The process and methods that we used allowed us to catapult how we can most effectively utilize and engage our patient family advisors. This also led to how we can actually embed our patient and family advisors directly onto the unit. We really didn't use much to implement this project as far as resources go. Frontline clinicians really had very minimal involvement from a resource perspective. No money was allocated or required to implement this project. And we received, as you could already tell, an absolute wealth of information and valuable information to help us improve our care directly at the bedside and in more real time, which I think was also a huge objective to this project. We wanted to see how we could differ from traditional capturing of patient experience information vis-a-vis a survey upon discharge and speed up the actual soliciting of that experience information by capturing it at the bedside, feeding it back to unit leadership, and acting on anything we were able to act on immediately. That proved to be a big success. Where we're going to be improving, and we've started this already, as you notice, some of the, we had a large portion of our patients didn't have any specific requests. Maybe we could actually ask more direct questions around specific aspects of their care while keeping things more generic. We've already started that on the units now. We're improving the tools so it can be used across the hospitals. We want to create generalizability. We want to create some standardization in utilizing this same methodology. And I think, and we will do a better job of how we can share the results that we've more or less shared with you today with our levels of leadership beyond managers, so directors, executive directors, above, because a large portion of what we were able to extract from our patients on our units did have specific suggestions and concerns relating to system improvement. So just a couple of acknowledgements. The patients of the accountable units, we cannot thank them enough, particularly on the units of 4A, 4B, 3D, and MSU at the Pasqua, the ACU team, tremendous help, and then the accountable care unit co-leads of those 4 units, terrific support, and a lot of gratitude has to go out to the dedicated, immense hard work that we saw and from our patient family advisors. You can see all of them here on this screen. And if you And if we have been able to capture any aspect of your attention based on this presentation, whether it's to do with an accountable care unit or the methods we've done and utilized with this project or how we are moving forward with this project, please reach out with us. This information is provided here. That's it.
Thanks.
Thank you.
The whole team. We're running a little bit late here, so we won't have time for questions. Once again, asking you guys to stick around and look at the chat. I know I have some questions personally, so I'd love if you guys stuck around for a few minutes. It looks like there's been really good chat, or really good discussion so far.